I have to give you my disclosures. We always ask, have to say who we're financed by and various things. I have absolutely no drug company support in anything I do, but I have to declare I am passionate about harm reduction, and I really believe that naloxone, take-home naloxone, is saving lives throughout the world, especially in the US and in BC. So I will carry on from there. So this is just the overview that I'm giving you today. We'll talk a little bit about overdoses in Canada and in BC. I'll describe the prevention, recognition and response that we have introduced, how naloxone works, implementing the program in BC, and then rather than giving you sort of boring old facts that you normally get in talks, I'm going to give you the most frequently asked questions that we get from health service providers and address those. So hopefully, if you've got questions coming up, I will actually go through those and answer them before you get a chance at the end. And then talk about where we are today and some of the challenges around expanding take-home naloxone as much as we would like and into the populations we would like. So a little bit about opioid overdoses. Opioids, these are a mixture of either naturally occurring or synthetically made, extremely excellent painkillers, but they also produce euphoria and they are addictive. So they are excellent painkillers, but they come with problems as well. Because Canada has the dubious honour of being #1 in per capita opioid prescribing. We slipped up to #1 just recently. The US were ahead of us. And they have a way of looking at it through morphine equivalents. So looking at all the different opioids like fentanyl, morphine, methadone, all the opioids, oxycodone, and working out exactly the morphine equivalents, then we are #1 when we look at it per capita. And of course, if you have a lot of prescribed opioids, there's always the risk of overdose in people who are prescribed, but there's the risk of diversion and the risk of addiction, as I had said. So if we estimate in BC the number of people who die who are taking prescribed opioids as they are prescribed. So these are not supplemented by illicit drugs, but are actually taking them as prescribed. It's between 70 and 80 deaths per year that we see. And there's about 122 deaths of people who are being prescribed methadone or opioid substitution therapy. We have a bigger picture. We have more concerns when we're looking at the illicit opioids. Illicit drugs, as you know, are unregulated, and that means people who are obtaining drugs to use have no idea what the content is, or if they even get the content right, they don't know what the potency is, what the amount of that drug is, and also what else is added to it, what are the adulterants, what else is actually in it as well. We know from Coroners data we have about over 300 opioid related illicit drug deaths in people who are using illicit drugs. So that's over 300 a year. And I'll just give you a look at what's happened with the trends. There was a time in the late 1990s when we were incredibly high, well over 400 deaths occurring each year. And about half of those were in the Vancouver area. Vancouver declared an emergency situation, and because there was increased HIV as well as deaths and hepatitis C. And since that time, you can see the blue is the Vancouver. You can see it's actually declined over time. But back in 2011, unfortunately, we saw an uptick again. And this was related to an increase in the potency. We tend to, when we're talking to people who use drugs, use the terminology of toxic or more lethal, because we don't want people necessarily to be seeking something that is more potent. But basically, it was 3 times more effective and therefore causing deaths in 2011. When people looked at this and the coroners did an announcement, there was a thought, well, this is probably the downtown east side. But when we looked at where it was happening, it was actually happening, there were more deaths occurring in the Fraser region than there were in the Vancouver region. And you can see that latterly the numbers have not gone down after that heroin incident, because we've now got fentanyl as a huge problem. So you can see there the numbers are well over 300, and we're looking this year, it's 2015, it's not going to be any different. When we talk about numbers from the coroner's data, it's always provisional data for the last year. It takes a while for cases to be closed and for the details to be looked at. But these certainly give you a good idea of what it's going to be. I thought because we're on the island that you would be interested to know that there are about 50 deaths per year that occur on Vancouver Island related to illicit drug overdoses. And there's been about 50 since 2011. So the last 3 years. So again, it's a considerable number of deaths that are occurring. So why do we even consider take-home-naloxone? And obviously in 2011 we saw that increase in deaths, and we work very collaboratively with the coroners, with the ambulance, with health, so we try and be at the forefront of what's going on. And US colleagues would say, why haven't you got take-home-naloxone in BC? You've got a supervised injection site. Now, come on, you've got the only one in North America that's officially sanctioned. Why haven't you got take-home-naloxone? In the US, they've been actually distributing naloxone, often quite locally, but for over 16 years at that point, and had lots of evidence to show it worked, that there wasn't an issue, and a lot of the evidence that I'll be quoting later on is actually from the US data, because if they've done it and researched it, we might as well use it as well. Now, I am going to have a little video here, which we've been working with to get the sound. So not only did we see an increase in deaths, we also saw that it works, that take-home-naloxone was a really good program, that the US supported it, and if they can do it in the US, surely we can do it in Canada. And then there was also the plea from people who use drugs. And I think that's very strong as well. And what I was hearing from folks in Vancouver was that they were going to conferences, harm reduction conferences, and there were some sites. Edmonton started their take-home-naloxone program in 2005, and they would come back with their vials so that they actually had some that they could use. And this is just a little snippet that we recorded.
Good morning, Bandu. Laura speaking.
Bandu stands for Vancouver's Area Network of Drug Users, and it's a place where people can come for harm reduction supplies and to be safe. But without naloxone, we can't do that properly. One of the things we're dealing with the most in the downtown east side is ODs from opiates. Naloxone reverses the effects of an opiate overdose.
I'm just going to put you on hold for a minute.
Naloxone is available to the public in many parts of the world, including the UK, Australia, Germany, and 17 US states. But in BC, the drug is restricted to hospital use, forcing organizations like Bandu to order shipments in from Seattle.
And I know right now that there's a hard time getting naloxone and that we really need it. If it can save somebody's life and they know that, I don't understand why we're not getting it anyways, because it feels to me like they're paying God.
So, I mean, when you hear stories like that, it's really meaningful, that it makes you think, come on, we need to do it. And I think the reason that we hadn't in BC was because nobody had said, okay, this is I need to do it. That there wasn't somebody who had identified. And so we thought, well, we do harm reduction. We distribute the supplies, the needles, the cookers and everything else throughout the province, but maybe this is something we should be taking on. So rather than just initiating a take-home naloxone program and just focusing on naloxone, we felt we had to introduce something that was a little bit more broad, so training and education around prevention of overdoses, how to recognize an overdose, and what to do about them. So we kind of coined our phrase of prevention, recognition and response. So it's nice and easy to remember. And prevention, it was messaging around not just opioids, but also around stimulants as well. And of course, how to use more safely as well, to always use with somebody, to just taste the drug first, and standard messaging that we all have. Don't mix, especially don't mix downers, don't mix opioids with other things that will perhaps increase the depression of the respiration, and don't mix alcohol with it as well. And thinking about routes of how you administer the drugs, that obviously injection is probably the most dangerous, and that smoking is less so. We also looked at recognition, and we've heard many, many stories, and it really is quite tragic when you hear a story about somebody who comes home, finds their partner sleeping, maybe snoring. They leave them, let them sleep, and then the next morning they are deceased, they have died. So it's an education about how to recognize, how to make sure that you stimulate and make sure that person is just asleep and is not having problems. With the response, I mean, this was always interesting. There's a lot of myths around as to how you should respond to an overdose. And certainly with an opioid overdose, we've heard about injecting salt water, injecting milk, slapping somebody around, making sure they walk, putting people in ice baths. And for the men, it was putting ice on their testicles. I'm not quite sure what that was meaning to do, but these were the things that people actually tried to bring people out of their overdose situation. So within that, we developed a very simple 2-page, and there are leaflets at the back if you want to take them. And this is basically what we kind of base our training on. It is quite a high level, but it in the writing, but it means that when you're talking to somebody, you can actually go through all the steps and make sure. And as I said, it includes stimulants as well. So it's not just opioids, it has how to recognize and prevent stimulant overdoses. And as I said, it's just on the two sides. So who is at risk of an opioid overdose? And certainly people who use illicit opioids, and I showed you the graph where we're now seeing 340 or so deaths related to illicit drugs. People have probably heard of fentanyl and what's going on, and this wasn't something that directed us to introduce the program, but I think it illustrates how important it is to have the program. And there has been illicit fentanyl detected throughout BC, in Alberta, in Saskatchewan now, and certainly out east as well. When we used to have OxyContin, which was a extended release oxycodone version, and that was fairly easily abused. You could crunch it up and snort it, you could dissolve it and inject it. And when the manufacturers stopped making it, it was just before the patent was coming to an end, and they introduced OxyNeo, which is much harder to abuse. People were very concerned that there would be a run on fentanyl patches, which was fentanyl's probably 80 to 100 times stronger than oxycodone, the morphine is. So it's really, really quite toxic. But in fact, in BC, we didn't see this much of an issue because we ended up by having all this powdered fentanyl coming in. Now, we don't know where it's coming from. It appears it's probably not manufactured in or produced in BC, but it's coming in and it's being put into tablets. And as we said, it's unregulated market. So when you're mixing it with caffeine, you're not making sure that there's the same amount in each of those tablets. Those little green tablets are called green monsters or green meanies or fake oxy, and they have CDN on one side and 80 on the other. So they're marauding as oxycodone 80 milligram tablets. Our information from enforcement is that when they've seized the tablets and they've tested them, it varies in the amount of fentanyl that's inside them, that it can be very little to a very toxic, lethal dose. The fentanyl powder has been sold as heroin, it may only contain fentanyl, and we found that when there was some overdoses at Insight over the long weekend of the Thanksgiving. But we also, some people now are actually looking for the powder that has fentanyl. Sometimes it's mixed with heroin, sometimes it's mixed with other drugs. And because people don't know what they're buying, and potentially if somebody has not been taking opioids and they're exposed to a drug with fentanyl in, it can have disastrous effects. It's also an issue, as I said, in Alberta and across the province. And these are just some news articles that came out around the long weekend of the Thanksgiving, when the police were informed that there was overdoses occurring. So they inform myself and other health authorities, who then inform the ambulance so they're aware, and the emergency room so they're aware as well. And it went from just being, sort of 14, 16 to actually going up to 30. And then over that long weekend, we saw there was at least 40 overdoses that were occurring. Now, because this was occurring at Insight, of course, they were able to they have naloxone there at Insight and were able to reverse them. And there were a number in the community that were also reversed by the take-home-naloxone. These are just a couple. The last one is the Flaps. The police obtained some substance which was similar to that which people had been injecting at Insight, where they had said they thought they were using heroin, and they tested it and it contained pure fentanyl and caffeine. There was no heroin in it at all. And I think this just gives you an idea of what's happening with the fentanyl. This is sort of 3 monthly overdose deaths. You can see overall the deaths have not been really increasing over those 3-month periods, but the proportion that are related to fentanyl are. So although we have introduced the take-home-naloxone and potentially have been reducing deaths, generally the fentanyl is a bit of another story, that people are using it and not being aware. And we had a provincial health officer's alert, and you can see actually after that it did go down a bit, so it kind of helps us feel that maybe it is worthwhile alerting people who use that, there is something out there, be a bit more careful. There was a coroner's alert, and you can see on that one, after that alert, it was steady, but then it's crept up again. So it's really quite worrying that this doesn't appear to be going away. And we did do a media alert, and there is a web page that you can go to, because one of our concerns was that it wasn't just people who were using the standard downtown east side or folks who were using illicit drugs on a regular basis. It was also people who were going to parties, recreationally using and using these little green meanies or these fake oxys, and overdosing and dying, not aware of how strong and what a problem it was. The other group that is at risk of an overdose is people who are on high-dose opioid prescriptions, so over 100 milligram morphine equivalents, and also people who are entering and leaving methadone programs. So the opioids, if you have not been exposed to opioids, you can be very sensitive to it and have an overdose, and then over time tolerance does develop. Now, you may be aware that in February of last year, we introduced the methadone was actually changed to methadose, and this is 10 times more potent. So methadone was introduced. The new formulation was called methadose, and it is, instead of being a powder which is reconstituted and with tang flavored, it is now distributed dispensed as a liquid which is pre-formulated, and it is 10 times the strength, so people are taking the volume which is 10 times less. So again, we were concerned that this might be an issue. People might get confused, and especially in people who were taking diverted methadone may be less aware, although the flavour changed from being orange to being cherry. So we developed some posters, and I think we were fairly blatant there that it could be very dangerous by our skull and crossbones. So these are the other groups that are populations at risk. And so it's people who are taking illicit or prescribed opioids who have other factors. So if somebody already has a respiratory problem, it can add to that and cause a problem, more severe problems. People with kidney and with liver disease, so if you're not excreting the opioid, or if you're not breaking it down as well. People who are taking other tablets or other medications that are also depressing the rest of the breathing. So benzos, benzodiazepines, sleeping tablets, alcohol, and some antidepressants. Another group at risk that we're really concerned about are people who have reduced tolerance because they've been through a period of abstinence. And that might be because they've been in treatment or in detox, or they've been in prison. So in prison, we know that potentially people are not taking the same amount of drugs that they had previously been. They may be in abstinence, they may manage to get some, but when they leave, if they take the same dose that they'd had previously, they can have an overdose. So the same amount that they thought they could tolerate. And the other group that aren't necessarily at higher risk of an overdose, but are higher risk of the serious consequences, are people who live in rural and remote areas, because it can take quite a while for an ambulance to get there. And the ambulance in BC all carry naloxone, and that's great. But in the middle of winter in a remote community, it can take a while to get there. And, we talk about deaths because we can count those, we can measure them. But there's also, if the brain isn't getting enough oxygen, that it can be suffering from brain damage, which can be a permanent disability for the rest of that person's life. So it's important to be able to respond quickly to get oxygen to the brain. But the good news is there is naloxone. And naloxone is also known as Narcan. And it's been around for 40, 50 years now. It is very effective. It is very quick acting at reversing an opioid overdose. It's an antidote, basically, and it's a pure antagonist, which basically means is it has no effect. Unless there's an opioid in the body, it has no pharmacological effect at all. So there's no risk of abuse. You cannot get addicted to it. I'm going to have to put my glasses on because I've got a really small screen and I don't want to miss out on saying things. And it's also recognised as a WHO essential medicine. So if you look at that little diagram, the opioids are on receptors in the brain. The naloxone has a stronger affinity, so it actually binds to the receptors more tightly than the opioids do, so it pushes the opioids off. When the opioids are removed from the brain, from the receptors, the breathing can be restored. And usually it takes between 2 and 5 minutes for that to occur, so it is pretty fast acting. It lasts for about 30 minutes and then it starts wearing off. It lasts up to 90 minutes. So there is a concern if somebody has had a large dose of opioids that it will reverse the overdose, but the overdose may come back. And that's why we advise people you have to stay with the person who's had an overdose, but also to call 911. And in our kits, as you'll see in a little bit, that we actually have 2 ampules, so sometimes a second one is needed. So having decided that we were seeing an increase in overdoses and that wasn't going to go away, having heard the pleas from people who use drugs as to how important it was that they needed something like this, and then knowing from our colleagues in the US that this is easy to implement, it's really acceptable and it's very effective, made us decide that we were going to do it here in BC. And I'm not going to go through that list, but you can see before we started, we spoke to anybody that would talk to us, from medical to nursing to pharmacists to police to ethicists to legal folks, just to make sure that we understood in the Canadian context how naloxone was licensed, who could prescribe, and if there were any issues that we needed to deal with. And we got quite frustrated at the time because I don't know if folks here remember, but there was a shortage of drugs that Sandoz was producing, injection drugs. So we got delayed and we didn't actually start, although we started trying to introduce things in January, February, we were going through looking at our program. It was August 31st before we were actually able to implement it. But it meant that we were able to develop all the materials. It meant we were able to put everybody's mind at rest that what we were doing was legal and was not going to have any problems. The first program, as I mentioned, was in Edmonton in 2005, and that's still going on, and it's a very localized program. And then Toronto had a program which started in 2011, and both BC and Ontario started in 2012 on the same day, which is Overdose Awareness Day, August 31st. Unfortunately, the Ontario program was actually closed for a number of months while some issues were sorted out, but it's now back up and running again. Okay, so these are the questions that we get frequently asked. How is naloxone given? Well, in BC and in Canada, the only form of naloxone that is available is for injection. Now, in hospitals, and I don't know if anybody here works in a hospital, but if you're in an emergency room, you often give it by intravenous injection. But it's, as you saw, 2 to 5 minutes is a response that you get if you give it in the muscle. So we use the injectable. In the US, they are using the intranasal, but injectable is what we have in Canada. You can draw it up from the ampules and you can actually give it through clothing. You don't have to find a bare arm. It's not like giving an immunization. You just want to get it into the person as quickly as possible. And it can be in a muscle, either in the buttock, in the thigh, or in the arm. So many people will just give it straight in the arm. So that's how we give it. Can and why should non-healthcare personnel be trained to administer take-home-naloxone? Yes, is the simple answer to that. It is easy to train people. And people who use drugs are excellent at drawing up the naloxone. They're probably far better than, me when I'm kind of in an emergency situation and shaking a little bit. There is no problem. Obviously, if somebody is not used to using needles, there can be that increased anxiety. And we know in people who are using illicit drugs, about 80 to 85% of people, if they overdose, do so in the company of others. So to actually have the naloxone with you that somebody can administer to you. It is a prescription-only medication, and out of all the ones that we've had where we've had overdoses reversed, actually 2 people said they gave it to themselves because they knew there was something wrong, but usually it's somebody else that administers it to the person who is overdosing. Who can receive a kit? Well, it's a prescription-only medication at the moment, which means you have to be at risk of an opioid overdose, and it has to be prescribed by a physician or a nurse practitioner. Except this week, we heard some good news that we've been working with the College of Registered Nurses at BC, and the board has approved a decision support tool so that nurses will be able to dispense naloxone without a prescription. Now, it's going to take a while for that to go through the process. Okay, thank you, Nanaimo. So, I mean, that's fabulous news. But it'll take a while for that to go through the process. And of course, it's up to whoever is employing the nurse as to whether or not that's acceptable in those areas. But, we're working hard to make sure that we can get it out to as many people as those who need it. So that was really exciting news that we had there. The fact that it is only for people who use opioids is a concern because as I mentioned, you're not going to give it to yourself, and usually they are giving it to somebody else. But that's what we have to do within the Canadian regulations and Health Canada and the way that currently take-home-naloxone is licensed. Naloxone is licensed. So what effect does training have on people who use drugs? And this is a question that we frequently get is, won't people use more drugs because they've got something that can prevent them from dying? Well, the answer is no. I mean, nobody is going to use extra drugs and risk having that high taken away from them just because they have naloxone. So there's been no evidence at all that people will take higher doses of drugs just because they've got naloxone. And in fact, the opposite happens. When people are trained and educated, people often will use less drugs. And what they found in one study in the US, I haven't put all the studies up on this presentation, but if you go to our website, towardtheheart.com, they're all there. So there is no, people are actually having less overdoses having been trained. I think if we tell people we care about you, we don't want you to die, and we trust you to be able to carry this and potentially administer it to somebody else, that's sufficient for people to say, okay, let's reappraise what's going on. Is it legal for someone, again, I'm going to put my glasses on, is it legal for someone to administer to another person to whom it's not prescribed? Yes, in an emergency, you can administer CPR, you can administer an EpiPen, you can administer naloxone. And that we checked with various legal entities just to make sure in an emergency situation, you will not be sued or anything if you actually intervene. And we know probably about 90% of people where it's administered are actually administering it to somebody else rather than that kit being administered to themselves, that they're carrying it. So do people who receive the take-home naloxone go into withdrawal and become aggressive? And this is something we often get for folks that work in the emergency room, because they're used to seeing people who perhaps having given intravenous naloxone in high doses. And we're actually evaluating our forms that we get back from people who have been given naloxone. And what we have found is that 51% report no symptoms and 36% report mild symptoms. So we're only using 0.4 mil in the kits that we're dispensing. And what we want is that to be enough to get people to breathe, but not enough to send them into withdrawal. Because the last thing you want is to have somebody who gets aggressive or starts looking for more drugs, because obviously, as I said, it can come back again. So what does training look like? And we have developed training material. We have developed the handout that you have. We have a pre-test, post-test, if people want to answer questions and have a look. We have a certificate when somebody has completed, and we make sure that that person actually can answer all those questions and is aware of issues around naloxone and how to recognize an overdose, how to use it, and what should be done afterwards. The interesting thing is that, you know, different people take different lengths of time. Some people who are well aware of issues around drugs, know how to be safe, know how to prevent and recognize, can have a 5-minute training, and they have the knowledge to use the naloxone. We do some hands-on training as well. You can see the orange there with a syringe sticking in it, because we use safety syringes. So these are syringes that when you actually have finished administering the full dose, the needle retracts inside, so that there's no issue of a needle stick or bystanders or anybody else having problems. And that's different from the needles that people who are injecting drugs are using. So it's good for them to actually try it out, and also it sort of we've got water vials and people draw it up, administer to the oranges, and then so people can try it out. And we encourage people to bring friends and family to be educated as well, because if somebody has naloxone, it may be the friends or the family at home that will be administering it. The next question, are people less likely to call 911 if they have naloxone? Well, there's part of the training is to tell people why they should be calling 911. And I mentioned that the overdose may come back. There may be issues around another contributing factors. People may have other illnesses. They may be diabetic. There may be other reasons that we're unconscious as well. And we just want people to be safe and not to have any detrimental consequences afterwards. There are some studies that say if somebody's overdoses, there's about 30% of people that may not even call anyway. And we really encourage people to call, and that's something we're working on. And in fact, I have an MPH student at the moment who is looking into that, who is going to be interviewing the police as well as interviewing people about why they do or they don't call the police. And I'll show you some numbers there. As I said, we were developing our all the material, and it's a one-stop shop on our Toward the Heart page. There is a naloxone specific page which has videos, has everything you ever wanted to know about naloxone. It has a lot of question and answers, specifically for the police. We suggest if somebody's setting up a site that they contact their local police so they're aware the kits are there and what the kits look like and what they are for. And to do that regularly at intervals, one thing we have found is that police, especially somewhere like Vancouver, they change. There's a turnover and we have to remember to go back and update them. So we developed a nice little one-pager for them, which they would hand out every now and then. We've got question and answers for healthcare providers as well, answering the questions about the legality of prescribing to somebody when perhaps it's not going to be used on that patient, but used on somebody else. So everything you wanted to know is there. And including the details of how to set up a site to be a take-home naloxone site. And the things that we make sure that are available is that we identify who it is who's going to train, who it is that's going to prescribe, and who it is that's going to be dispensing. We adapted the Save Me just so it was simple and people could remember what the steps were. So the S is the stimulate, the A is to check the airways. If you stimulate and somebody is still unresponsive, we advise to call 911 then and not wait. The airways, and then ventilate to give breath. The airways obviously is to check to make sure there's nothing there. Evaluate if they're not coming around, if they're not breathing, then give the muscular injection, and then evaluate and decide whether or not you need, after about 5 minutes, to give a second dose. If you see, this is what the kit looks like, and you can see within that, it's actually got those steps inside. So if somebody is anxious and panicking, there's a reminder for them. There's 2 ampules. The little pill bottle has the person to whom it's prescribed. It has their name on it. And there is a number, and we collect the prescriptions that was issued for that person. So we have all the numbers. The form there is to have the administration details. So if it is used, it comes back and we can actually trace who it was that had that particular kit and who was the prescriber and who was the trainer. And as I said, there's other pieces in there. There's the rescue breathing barrier mask as well as gloves and some alcohol swabs. I would have brought a kit with me, but I decided to play safe and come over by Air Canada today, and I didn't think they would appreciate me bringing syringes actually on the flight. Float planes, they don't bother checking, but as I came by an airplane, I couldn't bring it. So that's about the program. That's hopefully answering the questions that you probably had. So we've been going now for just over 2.5 years. So where are we now? Where are we today? So we have 70 sites throughout the province. So we started off, I gave the first training at Vandu, and we now have 70 sites throughout all health authorities. And these are our numbers. So we have trained over 3,000 people, and that includes families, friends. People have adapted our training for shelters and for other places, other service providers, so that they know how to respond should somebody overdose. We have, you can see there the bottom number, the 1,500. That is with people who use opioids, and that's the number of kits that we've given, or number of people that have received kits. We've also handed out another 500. People, sometimes you lose the kits get confiscated, they get lost, but also naloxone has a shelf life of about 2 and a bit years. So we're having to replenish if somebody has a kit. So again, that's why we like to track and see where it's gone. So we have dispensed 2,000 kits, and we have had 200 overdose reversals. which is huge in that period of time. And you can imagine it started slowly and it's been building up. I mentioned about calling 911. Only 53% of those overdoses that we've got the information for said they had called 911. And it's really interesting, and this is, as I said, what a student's looking at, is that it seems to depend where the overdose happens. People are reluctant to call 911 if it's in a residence. The concern potentially could be that the police would turn up. If it's in a shelter on the street, at a single room occupancy hotel, people are much more likely to call 911. The other interesting thing is that in Vancouver, the police do not automatically turn up with a 911 call, which sounds like an overdose. So people obviously will call for an ambulance, and the police have introduced a policy such that they would not turn up routinely at these overdoses because they didn't want people to be afraid of calling unless there's violence, unless they are called by the ambulance, or unless somebody dies. So we're trying to sort through where people overdosed and the sort of call that happened. And I think, the other reason that people give for not calling is because they think the person's going to recover anyway. So why would they? So these are where the sites are. You can see we have 6 sites on the island out of our 70, and we have trained 500 on the island. And when I say we, this is the royal we. This is everybody who's working together with this. We at BCCDC provide the materials and the tools, and then it's folks that go out, the harm reduction reps, it's the site coordinators, and it's the nurses at various sites that actually do the training. The naloxone can only be stored at a site which has other drugs. They can keep under lock and key. So it tends to be a clinic, a health unit. It can be a methadone clinic, but it cannot be just a site where needles are distributed by an NGO because of the keeping of the kits. But people are really creative, and there may be training at one site and then go take your certificate and go and see a physician who has bought into it, who knows, who trusts the trainer, and then they will prescribe. So there's creative ways to do this. And on the island, there have been 17 overdose reversals reported. See, about 10% of our kits have been used to reverse overdoses. Fraser has a much higher percentage, and there have been huge numbers of overdoses occurring there. But we could do better. We need to get these out more, and we need to get them out further. In the US, in the MMWR article they had 53,000 participants, and 10,000 had actually used the kit. So that's huge, but as I told you, this was over a longer period of time. So we're probably looking at, over our 2 years, is 10%. But as sites are there longer and people have it for longer, it's probably going to be higher. On our Toward the Heart website, we have a site locator. So if you're interested in finding out where the nearest take-home naloxone site is, you can put in your own postal code or put in your city, and then it will show you where the nearest ones were. But I realise that when you do this, some of the ones in Vancouver are actually closer than Nanaimo, but that you wouldn't sort of fly to get one. But anyway, you can see where the sites are, you can see the addresses. Not all sites are open to everybody. Sometimes it's just for their own patients. So we do include addresses and how to contact them, just to check that that's okay. But that's an easy way to find where to go. And I've got a few slides from Heather Hobbs. Heather was unable to join us today, but she wanted to share some of the details that has been going on Vancouver Island. And it's available at all the AVI locations. They offer overdose prevention and response training. So at Victoria, Nanaimo, Courtenay, Campbell River, and Port Hardy. And as you can see here from this is a Victoria poster, that there is training on a Monday at 4 p.m. every other week. So that's a regular occurrence for people to come and to be trained. And there's also peer worker co-facilitates. And it's a really good way to foster dialogue between the clients and the service providers or the educators to find out other issues as well. It's not just around the naloxone. And this was, she also sent me this, which you can see, this is through AVI, that 90 kits have been distributed, 340 people trained, and 15 lives saved. So it makes you feel good when you think you've through the program that you've introduced, through educating people, when you hear about overdoses being reversed, it really makes you feel you're making a difference. And you can imagine how empowering it is for somebody who uses drugs to actually feel they've made a difference too. And Heather gave us her email address if anybody wants to contact her. So let's celebrate some successes. So we've got 70 sites. I've told you about the sites. Where else have we got the program? We have the first emergency department in Canada, was in the Royal Inland Hospital in Kamloops. And they have distributed just over 30 kits, and they have had a number of reversals that they're aware of. So again, this is when people come in with an overdose. What a good time to find somebody whilst they're staying there, they're being observed, they're perhaps concerned about what's just happened to them. So potentially it's a good time to train, to discuss and make a difference. St Paul's Hospital are just starting as well. They've distributed a few kits, but not many, but they're rolling along, and I'm sure it'll suddenly be a large number because of the clientele that they have, which is fabulous. And again, both these sites are evaluating the perspective of the people who are prescribing, but also from the clients as well. And as I said, it's incredibly empowering to actually have naloxone as a person who uses drugs to be able to think you can save a life. I do training, on a regular basis, and I went to Vandu one day and asked people why they were there to be trained. It was a group training, and there were 3 people who said, I'd had it used on me. I had naloxone. Somebody saved my life. I want to be able to do the same for somebody else. And that really is, people look after each other in this community, and we really have to support that and, be aware that really we could expand this beyond where we are now and to have a really good effect. The other group that it's been really well received is the youth, and this is the group, the inner city program at St Paul's Hospital, and the youth have really embraced it. And again, I think it's sending a message that we care about you enough, that we want to save your life, but we also trust you enough to carry this. And what other programs do we do where we say, we train you, now you can go and save somebody's life, and, it does no harm. It's really empowering. We've shared our learnings with various of the provinces, because obviously we've been doing it longer than most. And Quebec is looking to introduce. Alberta recently, they've been suffering from the same issues around fentanyl as we have, just announced that they have 300,000 to start their take-home naloxone program. We were delighted to be able to assist them and help them decide how much they should be asking for and what our experiences were. But we are a bit jealous that they got that funding within 6 weeks of us telling them this is what perhaps will be reasonable. It's Accreditation Canada's accepted the program as a leading practice, and we work on dissemination and evaluation. So this was a paper that we published, which is online for anybody that wants to. This was our first evaluation. As I said, we're evaluating a bit more. We've just had I don't know if people are aware of the health files. We've just had a health file that has been created. So again, if somebody's searching on the web, they can find this. And it's supposedly written in grade 6 language so that people can understand it. One of the groups that I mentioned that were at high risk of having an overdose are folks who are coming out of prison. who have been, their tolerance level is down. And I spoke a couple of times to Correctional Services Canada, and they now have in their guidelines and their discharge planning and transfer guidelines that you should talk to a person about harm reduction. So that's not bad for a federal agency to have harm reduction written in, but also that they should consider take-home-naloxone as being something and referring them to that site. And we're having discussions with BC Corrections, and I think within the months we will have a pilot study going on at 2 facilities in the Fraser Valley, 1 female, 1 male. And again, so that when people are released, that they will be educated and have a kit with them. It's not all roses. There are challenges. We've only got the injectable formulation, and there isn't a pre-filled syringe type. But there are drug companies who are looking at the intranasal. There is on the US market, this amazing one, which is a bit like an EpiPen that talks to you and tells you what to do. And it kind of, in this electronic voice, just tells you to put it on the thigh and just press, and then it tells you it's done, which is quite fun. But, that's about $800, depending on what our exchange rate is at the time. It's a prescription-only medication. We've made an effort to try and get the DST, the decision support tool, so the nurses can. Friends and family aren't eligible to be prescribed or to actually be given it. In the US, there's Good Samaritan laws as such that anybody who witnesses an overdose can actually get a kit. We don't have that here. In California, they've gone one step further where you can buy it over the counter. So again, we're having discussions. Discussions are ongoing with Health Canada about how we can make this not a prescription-only medicine. It is so safe. It's safer than an EpiPen, and yet it has to be prescribed. It's currently not on our provincial formulary, so that's why we're the ones that are actually handing out the kits, rather than being able to get it from a pharmacy and being able to claim back for it. And, there's limited access for people on treatment opioids, and we're exploring other ways to have it. So I am just going to finish up by saying thank you to so many people, including people who are behind me, and to people who use drugs for their enthusiastic and tireless advocacy in sharing their stories. And I just have one little audio that I'm going to play you now just to finish off. And I think the other thing that's really gratifying is the press are so positive about take-home-naloxone. Usually when it's about crack pipes, harm reduction, anything like that, it's a very negative perspective. But this one, we have Dougie is there seen as an angel. You don't hear that about people who use drugs very often. So I'm just going to finish off with this. Hopefully people will be able to.
Doug Nickerson is a homeless man and gaining quite a reputation for interventions like this. Doug told us about a recent incident.
I knew the young guy, knew his mom, and his girlfriend was screaming. And so I responded and gave him his injection of naloxone. Got him at the early stage, I suppose. He walked to the ambulance. They don't always walk. Quite often they're taken to the ambulance in a stretcher. But I ran into the guy's mother today, and I asked her how her son was. She said, well, he overdosed recently. That's what I told her. Said it was me. She hugged me. The feeling overwhelmed me. I guess you can tell by my voice, but yeah, you can't buy that feeling. That's something that's earned. When you can see the look in the mum's eyes when she meets the man that saved her son's life.
So I thought I would end with that. I mean, people who have been administering the naloxone have such heartfelt stories, and the press actually really are enjoying a good news story where this happens. And I think those of us that have been working in harm reduction for a considerable time need to find a way to kind of capitalize on that and actually have that positiveness around harm reduction in general.